So it's been a year since the COVID-19 pandemic took hold, and it continues to dominate our lives and has fundamentally changed how we've approached our surgical care for our patients. A year ago, when they closed down our operating rooms and our clinics, we still had to take care of our patients, especially our patients with carpal tunnel syndrome. And in Southern California, in my group, we had to really pivot and innovate and think of ways that we could get around the pandemic and the shutdown. And today I'm going to talk about how we reimagined the way we would take care of our carpal tunnel patients using the best available evidence that we had. There we go. So one of the things that's clear is that in medicine, in many ways, we tend to make things overly complex. And my goal today is to provide some tips and tricks in order to simplify how we take care of our carpal tunnel patients in a post-pandemic or post-COVID world. Prior to COVID-19, we had telehealth available to us. Virtual visits were available, but we really didn't use them very widely. And part of that was physician and patient resistance, some of which was generational differences. Actually, the technology itself was a bit glitchy in some ways with some of the video visits we were doing. But a lot of us look at our practices and we like to have a physical exam, and we rely on that. And we just didn't feel that that would be acceptable in our practice not to have that available to us. So we didn't widely accept this modality in our practice in Southern California. But once COVID-19 hit and we were required to socially distance, it really did force us to take on virtual care, and it began to be more accepted by patients and physicians alike. And once we started doing it, we actually started liking it. We realized that what we were doing was kind of an outdated model of care delivery. There were multiple visits with various providers, including primary care, neurology, PM&R, and the episode of care for carpal tunnel release patients was a bit clunky. Things tended to happen in series rather than in parallel, and we wanted to figure out, could we provide a one-touch carpal tunnel release? In other words, could we do a safe, high-quality carpal tunnel release episode of care that was essentially virtual, other than the day of surgery, where that was the only point of contact we had with the patient? So in the preoperative setting, some of the tips and tricks I want to talk about, focus really around virtual visits and ways we use that to streamline carpal tunnel release care. About 15 years ago, there was a paper in Core that prospectively evaluated 100 patients that were being treated for upper extremity problems, and they used a simulated telemedicine consult and found that the intra-observer and inter-observer reliability was excellent for diagnosis and treatment of patients. So the concept's been around for a while, but again, wasn't widely accepted until now. When you think about the consultation that we do for patients with carpal tunnel syndrome, a lot of us rely on electrodiagnostic testing, but we wanted to see, was that necessary, and could we eliminate that as one cog in the wheel, so to speak? Also, could we get away without doing a physical examination prior to the day of surgery? And for our patients that have diabetes or other medical issues, could we get away without doing a lot of preoperative testing and other points of contact in the process? So one of the things we utilized was the Carpal Tunnel 6 instrument that looks at the 6 most common aspects of carpal tunnel syndrome and grades in the following way. If you look at the scoring system, just the history alone, the numbness and the median nerve distribution and nocturnal numbness gives you a score of 7.5. If you reach a score of 12, it's an 80% chance that you have carpal tunnel syndrome. So we figured if we could get one physical examination point over the phone or over a telephone visit, we could reach that threshold. And you can talk to a patient and have them do a Phelan test over the phone that gives you a score of 12.5. And a paper that came out a few years ago looked at the diagnostic accuracy of this instrument versus electrodiagnostic testing and found that this performed equally well or even better than electrodiagnostic testing for carpal tunnel syndrome. We also know from a study done in 2019 that if you send patients for electrodiagnostic testing prior to seeing a hand surgeon, you're going to delay treatment for anywhere from 19 days to up to 90 days. So using this kind of questionnaire or instrument could be very valuable. The other aspect of the pre-op or consult is in diabetic patients, where certainly diabetic control is important in preventing post-op infections, but how important is it for a carpal tunnel release? That's the question. And if you look at the curve or inflection point, you see that at a hemoglobin A1C level of 11, it's about 2.5 times higher rate of infection. The question is, what does that really mean? Well, if you were to treat a patient with hemoglobin A1C level of 11 with a carpal tunnel release, you would need to treat 100 patients in order to see one infection. So the question is that risk, sufficiently large to require patients to delay treatment, to go to their primary care physician, to get more testing, and really delay the inevitable. And some of these patients, it's not realistic to think that they're going to get their diabetes under control. So this is just one more piece of the puzzle we're trying to eliminate. Looking at the intraoperative tips and tricks, well, a lot of us have a question as to whether we could safely move patients to the clinic from the OR. Patient comfort is a concern, infection rate, could we deliver antibiotics? Do we need antibiotics? For those of us who do endoscopic carpal tunnel releases, could we safely do that in the office? What kind of equipment would that take? And where would virtual reality come into play in this? And I'll talk about that in a second. So wide awake local anesthesia no tourniquet is a concept that we're all well aware of. It's been around for over a decade, popularized in Canada, where they had a lack of OR space and needed to move patients to the office. The concept is using lidocaine with epinephrine, and that allows you to do cases without a tourniquet. Certainly, you can get by without sedation in most cases, but some patients do need a little bit of relaxation, so I'll give patients a Xanax intermittently. No need for a pre-op area or post-anesthesia recovery unit, and there's no nausea, no need for admission. Now, this is the kind of setup we use here in my office. This is a guy I'm getting ready for a bilateral endoscopic carpal tunnel release, and he's ready to go. This is certainly cheaper for patients in our organization. It's an office copay, which is a lot lower than a surgery center copay. For our diabetic patients, there's no fasting involved, no IV lines required, and there's no need for antibiotics. Again, it's ideal for patients with morbid obesity, COPD, people with AV shunts in the operative arm, and people on multiple medications. So the technique I use is with lidocaine 1% with epinephrine 1 to 100,000, and it's been shown over and over again in a number of studies to be very safe. The only complication I ever see is a little bit of, I would say, jitters, or the feeling of having too much coffee from the epinephrine effect in some patients. It's pretty rare and it's not long lasting, so it's pretty safe. Lidocaine can be very acidic. It's about 1,000 times more acidic than the body pH. So a number of studies have shown that the pain of injection can be minimized by buffering the lidocaine with some sodium bicarbonate. So I add a cc of sodium bicarbonate to 9 cc's of lidocaine, and that essentially makes the pH effectively 7.4, closer to body pH. Now, the technique I like to use for a wrist block is a little different. I don't like to inject into the carpal tunnel itself. I like to do endoscopic releases, so I don't want that fluid in there. This technique, which I'll show here, is injecting through the FCR tendon. If you inject through the FCR tendon, you know you're not going to hit the median nerve. So I make a little fingernail mark, a little, 3 centimeters proximal to the wrist crease. I'll inject through the FCR. You'll feel a puncture as it goes into the tendon, and then one more puncture as you exit. And I'll just inject about 10 cc's at that spot. I'll have them pump their hand afterwards to kind of move the fluid around the tendons and around the nerve, and that really results in a good dense nerve block. I will do a little supplemental block right at the site of the incision and a little bit in the palm, just in case I need to convert to an open release. Moving on to antibiotics. Antibiotics, we've studied that extensively in the hand surgery literature, and it's definitely not necessary in clean hand surgery. In fact, the AOS clinical practice guidelines do not support the routine use of antibiotics in carpal tunnel release surgery. However, we continue to see surgeons use antibiotics for clean hand surgery over and over again. This is a paper that I did 10 years ago looking at 3,000 patients. And we found with carpal tunnel release surgery that there was no increased risk of infection whether you used antibiotics or not. And there wasn't any increased risk of increased risk of infection in diabetic patients either. So I do endoscopic carpal tunnel releases, and part of my hesitation in moving these patients to the clinic setting during the pandemic was, could I provide a safe endoscopic release in the office? And it forced me to look back at the literature and see what the differences really are between an open and endoscopic release, and what's the efficacy, what's the safety profile, and cost. What does it really show? And if you look at endoscopic and open releases at 3 months, there really isn't much difference in outcome. The endoscopic releases tend to have a little less post-op pain, a little faster recovery, but they also have a little bit higher risk of a neuropraxia. In my practice, that's definitely something I see. It's not common, but it is something that you have to think about. With regards to major nerve injury, however, if you look at the world literature, it's hard to really determine if there's any increased risk between one and the other. And that's where the debate continues. As far as the cost goes, there is a system available nowadays that you can use in the office. It's a disposable camera and disposable instrumentation set. And I've been using it regularly for about a year, and it works well, and it's very safe. And I've got a little video here in a second to show you. If you look at the cost comparison, this is a relatively new paper. I think it's coming out this month, looking at the cost of a reusable system versus disposable in the OR. And they're able to show that the disposable system does save you a little bit of money, kind of a marginal difference, but it is something that to think about. Here's the video I wanted to show. This is the clear cannula looking in the carpal tunnel. The transverse carpal ligament is above at the top of the screen. The fat pad is distal, and there's the knife coming in, and I'm releasing from distal to proximal. And this has been a kind of a real game changer for me to be able to move these to the office and do under straight local. Moving on to virtual reality, this is a study that was done by our hand surgeons in San Diego, Kaiser, and they published this as a poster presentation. This was a kind of a novel idea using an Oculus headset, which is a virtual reality headset during hand surgery in the office. And they found that using these videos of flying over Norway or beach scenes decreased anxiety levels by up to 50%. The only complications they saw were that there were some symptoms of vertigo in 2 patients, and 1 patient removed the headset because he just didn't like the content. So that's an option to think about. In keeping with the theme of a one-touch carpal tunnel release, I want to touch on the post-op tips and tricks and how we utilize some of the evidence that's out there in order to make sure that patients had a virtual visit post-operatively and didn't have to come back. Well, if you look at splinting, we know that for many years that splinting isn't necessary after carpal tunnel release. A good randomized prospective study looked at this years ago and found that there's no difference in outcome. So I no longer use splints after carpal tunnel releases. I started doing that early in my practice, and I've gotten away from it completely. A more recent paper looked at the duration of postoperative dressings after a carpal tunnel release and found there was no difference in outcome whether you kept somebody in a dressing for 2 weeks or had them remove it at 2 to 3 days. So now I let people take the dressing off at 48 hours, shower, and kind of move along. In order to have people do a virtual visit for the first post-op and not have them come back, I do a wound closure with topical skin glue. I guess you could potentially use absorbable sutures as well. But there isn't really any formal literature in the hand surgery world on using wound closures with skin glue. However, in the Journal of Injury, there was a study looking at Achilles tendon repairs, and they found no difference in infection rates and higher patient satisfaction when you use skin glue. As far as therapy goes, it's been shown in the past that you don't need a formal therapy program for your patients, that a good handout with a home exercise program is sufficient. And so this, again, keeps with the theme of a one-touch. They don't have to go see a therapist. They can do therapy on their own and have a very similar outcome. Finally, with the opioid crisis, the literature supports using non-narcotic pain management after surgery, and again, most of us are moving towards that in hand surgery. Opioids are commonly overprescribed, and certainly something we have to consider. This study found that the narcotic actually resulted in more post-op pain than the non-narcotics, and the pill consumption was essentially equal between the different modalities. So I guess the bottom line is, yes, you can do a virtual carpal tunnel release, one-touch process, and it can be done safely. So I hope this helps. I hope these tips and tricks will provide you with the ability to provide this type of care for your patients in a post-pandemic world. Thank you.
Thank you, Dr. Harness. I have one question and I will turn over to my colleagues as well. In your mind, are there anybody, I guess I'll take my screen back on. Is there anybody that you must see ahead of time before a telehealth video to assess for surgery?
Yeah, I mean, so what I didn't mention is that we're developing a pre-visit questionnaire where we basically have an electronic kind of questionnaire that goes out to patients, and it triages them for things like cervical disc disease, radiculopathy, patients that may have other symptoms of pain that isn't clear-cut carpal tunnel syndrome. And frankly, when we do our initial evaluation over the phone or video visit, we're going through that process with them. We're sorting out, is this person a classic carpal tunnel patient? Does this person fit the bill? Are they going to be able to handle not seeing the surgeon in person? We give them the option of seeing us in person if they want that. So they're never forced into that process if that's not what they want, or if we don't feel that that's appropriate for them. There are going to be some patients, though, in a virtual world where you might get to the day of surgery and find out they have a lot of pain from CMC arthritis, and you haven't had an X-ray, or they have a trigger finger that you didn't recognize, over the phone. And patients actually are okay with that. I've found that patients are accepting of the fact that there may be some things that we need to take care of that weren't essentially weren't easy to diagnose over the phone or a video, and that we can still take care of them in a safe way.
So you're really brave. I did 2 bilateral endoscopic carpal tunnels on Monday, and I had them go to sleep. So you can truly do those under a Wallant?
I will be totally honest. I was a general anesthesia endoscopic carpal tunnel release person until about 6 months ago, or even maybe a year ago. And I was reluctant to try it in the clinic, and I was a little fearful of the cannulation pain. And so far, so good. That block technique I showed is working really well. I do have a protocol where I have them take a 0.5 milligram of Xanax prior to the procedure. We give them a Toradol injection in the clinic, and we do the block. And I can say I've done about 45 of these now in clinic, and I think only two people had any kind of discomfort from cannulation. And that was my big fear. So it's surprising. I've converted.
Awesome. Great. Dr. Slater, Dr. Schroeder, any questions for Dr. Harness?
Yeah, I've got one for you. I like how you touched on the diabetic patient, because it's sort of a conundrum, I think, for us all. But you mentioned the patients with a hemoglobin A1C, and we certainly have many of those who have severe carpal tunnel, or at least hot severe symptoms, that would benefit from surgery. And we've counseled them to lower their hemoglobin A1C, and they just don't do it. So how do you approach it in your system? Because it seems to be, an issue in ours we know that they're going to be at a higher infection risk. And sometimes for the benefit of the patient, you talk to them about it, we move on to surgery, and then you have an infection. So I'm wondering how you guys approach that.
Great question. I think, even in our organization where we try to have things more uniform, it's still an individual surgeon decision. I would like to have the option, though, of doing these patients without further testing if we can, because it delays the inevitable. Like I was saying, there's these patients that are at 11 probably aren't going to do much better in a matter of 2 or 3 months. And I think that they need our care. The risk is still very, very low. Carpal tunnel infections are exceedingly rare. And even with a hemoglobin A1C level over 11, the data would say that the risk is 1 out of 100. And if you tell a patient that's in pain with carpal tunnel and has numbness constantly, that they have a 1 out of 100 chance of an infection, you can let them make the decision whether they want to move forward. I think that is a reasonable choice that a patient could make.
I always have several questions, but I'll just keep it to 1 or 2, Neil. And that is, your focus here was on the endoscopic carpal tunnel release, which is a whole debate in itself. And I wondered if you've had experience with doing the same kind of evaluation over the telehealth system, having the patients come in to do a mini open or any other procedures in addition to endoscopic carpal tunnel release, and what your thoughts are on that.
Yeah, I mean, definitely my focus was endoscopic, but we have also open carpal tunnel releases. We're bringing in trigger fingers, decurve veins. We've done almost everything you could think of that could be done in a local via a virtual or video visit. And there are certainly early adopters to this in our organization and people who are definitely against it. And so it becomes a comfort level for the patient and the surgeon. And we're moving more and more towards it, but I'm certain that there's going to be a limit to what we can achieve. And the biggest barrier, I think, which I mentioned earlier, is just having the problem of having somebody show up for the day of surgery and either the diagnosis is wrong or you have some sort of other diagnosis that you're going to have to deal with. And I think overall that's going to be pretty rare, but it is something you're going to have to be prepared for.
Great. Well, thank you. And it's probably an understatement that telehealth has been vaulted into the 21st century after the pandemic.